All right, well, thank you for having me, inviting me here. This has been a great meeting, a fantastic dinner last night while looking at the sunset. That was great. All right, so what are we going to talk about right now? Well, we're going to talk about spaceflight and one component of spaceflight that looks a lot like aging in some ways and how that links the vestibular system with brain-blood flow. A topic you probably have not heard too often. I just want to acknowledge the fact that lots of people have been involved in this work. It's been sort of over 10 years, and so I want to acknowledge all of those people, my colleagues in Boston, my colleagues at NASA, Dr. Black, who is a neurotologist who's passed away now, and my colleagues in Ireland. All right, funding came from NASA and National Institutes of Health. Okay, now let's get going. What happens when we stand up? That is really one of the big questions here. So when you stand up, you know, there's a translocation of blood that goes down below your heart, and so obviously we have to do all these adaptations to maintain our pressure, and we need that pressure to maintain brain blood flow. Quadrupeds don't have this disadvantage, so we have to basically deal with the fact that we have reduced perfusion pressure, so we have to dilate in response to that to maintain flow when we go upright. And so the question becomes, you know, we all know the cerebral autoregulation curve. So if you're normotensive and you go down onto this lower limb of the curve, you would be, you know, you're hypotensive and supposedly cerebral blood flow would drop. So what happens when cerebral blood flow drops? Can we start the video, please? Okay, so this is an astronaut at a post-spaceflight conference. She's been down. This is actually like a day later. And you see she gets all glassy-eyed and she passes out. Of course, being an astronaut, she gets back up and tries to finish the press conference. And then she gets glassy-eyed again, and then sort of isn't wherever she is, and then starts losing balance, and they are like, okay, we're going to take her away now. So this is actually a big problem with astronauts. It's called post-spaceflight orthostatic intolerance. And so what you get is you get these ultra-healthy individuals that, you know, have no problems at all, have no comorbidities, and about 60% of them can't maintain or can't do a 10-minute stand after they return from spaceflight. So we've been curious about that for a long time, and so to get at that, you know, you got to think about what could be going on here. So obviously, you need cardiac output to generate blood pressure. You need that blood pressure to generate brain blood, or to maintain your brain blood flow. If you don't maintain your brain blood flow, you're going to faint. Well, blood volume, we know, drops dramatically in space because of adaptations to the fact that there's fluid shifts into the thoracic. So for a long time, we've really been beating the blood volume horse to death, trying to blame this drop on this drop in blood volume reduces cardiac output and decreases pressure. Could there be something else, though? Because what happens is if we saline load the astronauts, if we do all this stuff, they still pass out on us. So it's not just blood volume. It's not just blood volume. So I was curious about something else, the vestibular system, and how that might play a role in this. And so the vestibular system tells us about our place in space, where we are, if we're upright and all that kind of stuff, provides us both linear and angular acceleration cues, and helps us to stabilize our bodies when we're moving. So I don't know how many people are into the vestibular system here, so we'll go through some very brief vestibular physiology here. So you got otoliths and semicircular canals located in your inner ear. Semicircular canals are these round organs that are involved in angular acceleration. The otoliths are involved in linear acceleration, and the way it works is you've got these hair cells with this gelatinous mass, and sort of they're embedded in the top of them with these calcium carbonate crystals. So that's the otoconia. And so what happens is when you bend those hair cells, you basically increase the firing rate of those otoconia. So the idea is that it's basically a kind of an inertial system. So if I'm here and I start walking across the stage, that otoconia wants to stay where I am, but I'm moving, so I drag the hair cells with me, and so that causes them to bend. And so my brain can tell how fast I'm moving from the bend of those hair cells. So it tells me exactly how fast I'm moving. Another very important situation is when you tilt your head. So one thing I always do when I'm teaching classes is you imagine if you're standing, you're looking out, and you close your eyes, and you tilt your head, this is upright. How do you know that's upright, right? That's an otolith-mediated tilt. So when it tilts, your otoconia bends those hair cells, and that tells you exactly how far you're tilted. And so that's why you still can tell where upright is, even though you have no visual information. And if you put people into environments where they have no visual and no somatosensory, they're still pretty good at telling you about what direction up is. Okay. So, start the video. So here's an example of how effective the vestibular system is in stabilizing head position. So we have our friend the owl here, and what you can see is that the head's not moving at all. Like, even though we've got some serious motion. Now, of course, what you can say is this is just because the owl gets to like stare at a point in space and it's fixating on that point, kind of like dancers do when they're spinning around and all that kind of stuff. Well, in a second, we're going to blindfold the owl and do it all over again. And so what you see here is, again, even though the owl has no visual cues, has no somatosensory cues of where they are relative in space, they're able to keep their head completely still. And that is your vestibular system in action. All right. So what? So it's involved in stabilizing your head, but who cares, right? How's that going to affect your cardiovascular response? And that's what we were really interested in because we're talking about fainting. Well, if we take a cat and we tilt them 60-degree nose up, they're really good at maintaining their blood pressure. We take that same cat, we cut the 8th cranial nerve that gives information from the vestibular system, and they suddenly have this huge drop in pressure when we tilt them up. And so that was some initial work that really showed that the vestibular system might be an important component in helping you to maintain blood pressure when you are going upright. Okay. So, could this be a vestibular input? I think it could. So, well, but there's one problem. Not all the astronauts show blood pressure drops when they become lightheaded and have to sit down. So here's a classic example of a subject. This is an astronaut post-flight. They're lying down. They stand up. Blood pressure's fine. Blood pressure's fine. Blood pressure's fine. Blood pressure's fine. And now they're so lightheaded, they need to sit. So did they just wimp out, or what was going on, right? So the question becomes, what about brain blood flow, right? So even if pressure is being maintained, they were getting lightheaded and they needed to sit down. Could that be because their brain blood flow is actually lower, right? We were just measuring blood pressure in that last one. So why would the brain blood flow be lower if the blood pressure is fine? One of the things you have to think about is that when we go from lying down, where our mean arterial pressure is generated at the heart about 90, our head's also getting that same mean arterial pressure. However, once we stand up, we now have a 1GZ vector that is causing a pressure gradient across the body. So now our 90 mean arterial pressure, which we're measuring at the heart, so in that astronaut we were measuring that the whole time, they're only seeing about 70 millimeters at their head. So every time you stand up, you've got to dilate your brain blood vessels to maintain your blood flow, right? Because of that hydrostatic gradient. So even if you're doing a great job of generating mean arterial pressure, you still have to deal with that hydrostatic gradient. So one of the ideas is that when you're supine and you go head up tilt, now you're sliding down the cerebral perfusion pressure curve here because of the hydrostatic gradient. So I guess the question really becomes, is blood flow an issue in orthostatic intolerance? So we did a study on the parabolic flight plane at NASA, also affectionately known as the vomit comet. And it basically gives you 40 cycles of 25 seconds of 0G and then about 45 seconds of 1.8G, and it alternates back and forth and back and forth and back and forth. And if you don't get sick, which 70% of the people on the flight get sick, if you don't get sick, it's the best roller coaster ride of your life. If you do get sick, it's the most horrible experience you'll ever have. I have a colleague who can't even step on the plane. The smell alone makes him nauseated, the smell of the plane. So very low, strong, aversive learning there. So we did a study where we looked at mean flow velocity in the MCA, and what we did is we took a bunch of subjects and we tilted them pre-flight, then we flew them on the vomit comet, and then we tilted them post-flight after the vomit comet. So all of them completed a 30-minute tilt test pre-flight. So they were all fine for 30 minutes pre-flight. When we landed, half of them were able to complete the post-flight test and half were not. So in the ones that were able to complete, what we found was We saw about a 10% drop in cerebral blood flow early in that tilt, and by the end of the tilt, these are the last 45 seconds of tilt, there was about a 15% drop, but it was the same whether that was pre-flight or post-flight. They showed us the identical response. In contrast, the people that that developed pre-syncopal symptoms when we were post-parabolic flight, pre-flight they had a slightly bigger drop in cerebral blood flow, but then it was stabilized around the same sort of 15-17% here. But what we saw post-flight is that they showed a significant drop in the last 45 seconds. So here they had a significantly lower cerebral blood flow in the last 15 seconds before they passed out. Well, they didn't pass out, but before they became pre-syncopal. What was really interesting is their pressure was actually higher post-flight. They had higher mean arterial pressures post-flight than they had pre-flight. So they were actually showing bigger drops in cerebral blood flow, even though they had higher pressure. And this was kind of like that astronaut connection. Now, the thing about this is that, all we did is we took them on a plane and had them experience 25 seconds of 0G, 40 times, right? So that's not an adaptation response you would think. It's not like sending them to space for a week or a month or 6 months or whatever. So what could be affecting the brain blood flow? So we have this unknown connection. Well, could it be vestibular? Right? One of the things about the vomit comet, why do we call it the vomit comet? Because it's a hugely difficult vestibular challenge. And so your vestibular system has to adapt to this constantly changing gravitational state, which is something that you don't ever experience under normal conditions. So I started getting more and more interested in this. So then we actually started to look. Tried to figure out, are there anatomical connections between the vestibular system and cerebral blood vessels, right? Could there be a connection there? And in fact, I won't go through all of this right now, but if you go through this whole thing, you can actually see that there are connections from the otolith through the vestibular nuclei, through a lot of the cardiovascular areas, the NTS and the RVLM, as well as the vestigial nucleus to the palatine ganglia, to the cerebral vessels. So there does seem to be an anatomical connection. All right, so there's an anatomical connection, but is it actual functional? Does it do anything? Is it important? So we wanted to explore that, so we decided to recruit a group of patients, labyrinthine deficient patients. So these are people who don't have otolith function anymore. So remember we talked about otolith tells about your place in space and where you are, and they tell you about tilt. Well, these patients don't have that sense of tilt. They can't tell where upright is once they close their eyes. So what we did is we tilted them in different directions, and we just wanted to see whether they were different. And basically the take-home message for this one is if we look at the flow velocity in the MCA in a control group versus a bunch of these labyrinthine deficient patients that don't have vestibular systems, otherwise they're matched for age and gender, they're not older, there's nothing there's nothing wrong from the cardiovascular perspective. We saw there's a significantly lower blood flow when they were tilted up than the controls. However, their blood pressure corrected so that it was at brain level, so we're taking that hydrostatic gradient out of there, was the same. So again, this was a situation where we had a drop in cerebral blood flow, but really no drop in the perfusion pressure. So we were thinking, okay, is the brain being directly affected by the vestibular system? So is there something going on there? Well, now it gets complicated. All right, so now we want to try to figure out whether the vestibular system is going to affect the brain. Well, now we have to stimulate the vestibular system. Well, so the vestibular system is based on acceleration. So to stimulate somebody, give them an acceleratory stimulus, you spin them. That's what we tend to do. So we took these individuals and we put them on a centrifuge. So they're sitting on a chair. Centrifuge spins up, spinning around. So imagine this is like a propeller blade on a plane. So it's spinning. And then you can slide them back and forth along the propeller blade while it's spinning. What that does is that you're creating a linear or a centripetal acceleration that is giving them perception of tilt. And the most amazing thing about this paradigm, it's totally done in the dark, so they have no visual information, is, I was one of the subjects, and I'm on the chair, I'm being moved out to the end of the arm, and I think I'm being tilted forward. I know I'm not being tilted forward, but my brain is like, really makes you feel like you're being tilted forward. So it was interesting. So what we did is we did that, and the nice thing about this is there's no change in the hydrostatic gradient here, right? There's no change in the acceleration between the head and the heart, so we don't have to deal with that kind of change. We also did just a standard tilt where we had people swinging back and forth on a chair to look at the sort of standard response versus our very specific otolith only kind of stimulation. What did we find? Well, we found that if you oscillate the chair at 0.0625 hertz, so this is either tilt or centrifugation. So centrifugation, we're sliding them back and forth along that propeller blade at that frequency. During tilt, we're just tilting them back and forth. But basically what you say is you get the cerebral blood flow starts to entrain to the frequency of the stimulation. What's interesting is that the entrainment of the cerebral blood flow is different than the entrainment of the blood pressure. So the blood pressure was also being affected by that vestibular input, but it was at a different rate. And you can see that at the 0.25 hertz, it's dramatic. Flow was going down while pressure was going up, which is completely the wrong way, right? So the pressure should have been driving the flow. This is pretty fast, you would have expected, but in fact, no. So this started to make us think, man, there really are some vestibular inputs going on here, and that these vestibular inputs do seem to have a direct effect on cerebral blood flow that is independent of that effect they have on blood pressure. And we couldn't explain that through other things like changes in end-tidal CO2, so it does look like we've got this connection, this vestibular brain blood flow connection. Okay, so we got that all going, but what does it have to do with aging and spaceflight, which is where we're supposed to have started, right? So the thing is, during spaceflight, you no longer get a gravity signal, right? You go in space, you no longer get this gravity, you no longer get this upright signal. The problem is that when you are in the space station, and you look, you can see the lights are up here and all that kind of stuff. So you're getting this visual input. So the problem is that if you then tilt your head, your vision tells you that your head's been tilted, but your vestibular system says, we haven't moved at all, and that is not a good situation to be in. Anybody who's been in a boat, in the cabin, when the boat's going up and down, and that cabin's not moving, and visually does not move, you start to feel not so well, and that's a classic visual vestibular conflict. And so what your brain has to do is has to say, okay, how are we going to fix this? Well, the easiest way to fix that is to ignore the vestibular system, right? The vestibular system's not telling you about tilt anymore, so you sort of reorder the way you interpret that to say, hey, it's not about tilt. So what's interesting is when the astronauts return and you tilt them, they actually will describe that as if they're being translated. They feel like they're being translated instead of being tilted because they're interpreting all linear acceleration as translation rather than tilt. Okay, so why would that be important? Well, if we think about it that this is an adaptive mechanism, the vestibular system is helping us dilate when we go upright, it's going to help us when we get that sense of tilt that we're going upright, and therefore it's going to be important to that initial dilation when we first go upright. If you no longer interpret tilt as tilt anymore, you interpret as translation, you may not have that dilation. Well, it also turns out with aging, we have a loss of otoconia hair cells, and we have a loss of perception of tilt as well. So both groups are sort of not getting that vestibular input. And you can kind of see that in this graph here where we have the elderly and astronauts. So one of these groups is pre-post-flight astronauts, and one of these is young versus old. And normally I take hands and have people guess which one it is, but we've got a big crowd and we're running out of time. So anyways, what you see is this is sway parameters under different conditions, and you can see that this is our young and our elderly. So young people are pretty good about maintaining sway. Elderly people get huge amounts of sway when they don't have visual inputs and they're on an unstable surface. When we look at the astronauts, it's like your super healthy astronauts here. You send them into space, they come back, they start to look a lot like a 70-year-old. They really, and if you look at their gait, they look like they're this sort of old person. So what does vestibular dysfunction look like? Well, I don't have any videos of vestibular dysfunction in humans, but this is a classic acute vestibular loss in a dog. So you can see the gait's really off, and you see that head tilt. That's a very common that you get that immediate head tilt. All right, so very clear that that's vestibular dysfunction. Okay, start this video. This is the same dog a few months later. Or which dog is it? I mean, this is no longer a clear vestibular dysfunction dog. However, if we tested that dog, you can see there's some weird little gait stuff, but we tested the dog, no vestibular function. And so you're really good at using other things to adapt. So when you see the astronauts come back, see, you still got the head tilt a little bit, right? When the astronauts come back, they also have this sort of weird gait, but remember, they are compensating like crazy. And in fact, when you test them, their balance is not that bad, but you know what the big difference is? When you test an astronaut pre-flight, they're telling you jokes, they're laughing while they're doing the posturography testing, they're really not concentrating at all. Post-flight, if you talk to them, they'll tell you to shut up. They just want to concentrate on their post-flight testing because they really need to concentrate to do it well enough. So there's clearly something going on. So we were interested in that, so we decided to use aging as an analog of spaceflight. So we recruited 200 people in Boston, 100 young, 100 elderly, and we assessed their otolith function to try to see if we could differentiate the groups. If we start the video, so how do we assess otolith function? We put people in a completely dark room using infrared goggles. We can actually track their eye movements, and your eyes counter roll in the sockets when you're being tilted. So what you see here, if you watch these little features, the feature will go across the line and on the other side as they're being tilted. So as you tilt your head, your eyes counter roll, and we can measure that, and that's an otolith-mediated response. When we do that in those LD patients, they don't counter roll at all. There's none. And so when we assessed that, what we found was you see that there's ocular counter roll, there's a huge range, even in young people, but it goes progressively down as we get older. The depressing thing about studying aging is this is what all the figures look like. So the thing is this, what we decided to do was take individuals that had low ocular counter roll and individuals that had high ocular counter roll from both age groups, and you can see their counter roll was highly related to that sway area, right? So again, this is, if they have really poor counter roll, they have huge sway, so it's telling us about vestibular. So what we decided to do was look at those two groups, the low and the high counter roll group, as far as cerebral blood flow goes. And what you see is when you look at the change in cerebral blood flow velocity when you tilt them, so the reduced ocular torsion is the solid bars, the normal ocular torsion is the white bars. We got young, we got old, but what you see is that it didn't matter whether you were young or old. If you didn't have a good vestibular input, you showed a much bigger drop in cerebral blood flow. And we didn't see that in the mean arterial pressure. So again, we see this unique cerebral blood flow only kind of connection. So what it seems like is that the vestibular inputs or vestibular loss of vestibular inputs could have a direct effect on brain blood flow, and that could be part of this orthostatic intolerance. So is brain blood flow impaired in astronauts? Well, there's some work where they looked at cerebral blood flow in astronauts pre-flight and on landing day, and they had two groups, non-fainters and fainters. But I mean, the big take-home message of this is here's the fainter group pre-flight didn't show much of a change in cerebral blood flow when they stood, or cerebral blood flow velocity, but they showed a huge drop on that landing day. So those individuals were definitely more or they had a bigger drop in brain blood flow. So what we really see here is, in summary, we're interested in what could be causing post-spaceflight orthostatic intolerance, and what we seem to have found is that the vestibular system may be helping to dilate your cerebral vessels when you go upright. If you lose that input from that vestibular system, you no longer have that sort of adaptive vasodilation of the brain, and you're more likely to show bigger drops in cerebral blood flow, even if your blood pressure is normal, right? And that's kind of that's why I think the saline loading and all the other stuff we were doing with the astronauts wasn't working, because we were treating the heart when we really needed to be treating the brain. So I'm at the U.S. Department of Veteran Affairs. That's the hospital. And this is just a last little video. This is actually in flight in the KC-135, the Vomit Comet. And so you can see it's kind of fun. You're like floating around, having a good time. But it's really an interesting thing, because before the plane hits 1.8 G, they say feet down coming out. That means you got to get your feet pointed towards the ground within 5 seconds, or else you're going to just hit the ground when the 1.8 G hits. And I remember I was doing these spins, and they said that, and I thought, I have no clue where down is, which is a really unusual sensation. It's a very weird, and so I managed to just spin around in time, but it definitely gives you an idea of how unusual it is not to have that vestibular input. And I just wanted to, for those of you that have are not aware, we've had the Cerebral Water Regulation Research Network meeting here, and if any of you are more interested in learning about cerebral water regulation, even though I didn't talk about it in my talk, you're more than welcome to go to the website and join. There's no membership fee, and we're always interested to have more people that are interested in cerebral water regulation. All right, thank you very much.